I would like to welcome all of you and our speaker today, Hani Nazal. Hani Nazal is Senior Consultant of Pediatric Dentistry at Hamad Medical Corporation. Dr. Hani completed his PhD and National Institute of Health Research Consultancy training in Pediatric Dentistry at Leeds University, during which he obtained his tricollegiate fellowship in pediatric dentistry from the Royal College of Physicians and Surgeons of Glasgow. His research interests are in the field of dental traumatology, pediatric oral health, and regenerative endodontics. So welcome all. Welcome, Dr. Hani, and the floor with you now.
Thank you very much. Thank you very much, Dr. Aidan, for your kind invitation and kind introduction. And thank you all for attending the lecture, both online and in person. I'm hoping today to cover the topic of the IADT 2020 Trauma Guidelines, a critical appraisal. So many courses to try and understand the logic behind some of the changes that were made in that document. And unfortunately, everybody who just presented, this is the old one, this is the new one, but really didn't critique it. So I made an effort to look into the literature to see some of these changes. I can't cover all of them, but I chose the ones that I thought are substantive. So I just want to declare no conflict of interest at all with this lecture. Actually, there's nothing commercial in my lecture anyway. This is not working. Okay, and I have to show this slide, so I'll leave it there for a few seconds. Okay, so I'm hoping by the end of this lecture to cover these objectives. So first of all, I'm going to give you just an overview of the prevalence of dental trauma in our region, in the Arabic region. I will also give you an outline of the available resources on the management of dental trauma. I will also discuss some of the results that we have shown in some of our surveys in the Arabian region in regards to the knowledge and confidence of general dental practitioners in the management of dental trauma. And the main part will be in critiquing the guidelines at the end. So this is a systematic review by Petty et al. In 2018, where he looked at the pooled global prevalence of dental trauma in the primary dentition and showed that it's 22.7%. And if we look at the bottom part in our region, you will see that the average, so the prevalence is also the same. So the prevalence in the primary dentition in our region is around 22.7. I looked at some papers in our region, and unfortunately there isn't many. So there's underreporting of the trauma prevalence in our region in the primary dentition. There's a study in Jordan in 2015, which showed 26.4, while in Saudi Arabia for 5 to 6 year old in 2001, it was 32%. So one study showing higher prevalence than the other. If we look at the permanent dentition, again, the same systematic review has showed a global prevalence of 15.2. And in our region, it's again not very far off. So the Eastern Mediterranean is 16.0, the African region is 11. So we're not far off. But if we look at the Middle East, there are some regions where it showed lower than the average, as you can see here, between 8.4, 6.1. There are some countries where they showed similar to the average. And in Palestine, which you would expect maybe because of the conflict, that it has a higher prevalence. And in Saudi Arabia as well, it's showing a prevalence of 34%. Now, these studies, if you look at them, we cannot compare them like for like because of the different methodology that was done in assessing these prevalences. And also some of them are quite old, some of them are new. But it gives you a hint of what's happening in the region. Unfortunately, we don't have data for Qatar. We are going to do a national survey, hopefully starting data collection in January next year. And one of the items there is trauma in the permanent dentition for 12 to 16-year-olds. So hopefully by end of next year, maybe I can share some of the prevalence in the population in Qatar, let's say. Now, this is an interesting study in Egypt, which was done in 2016. They looked at 8,000 children between the ages of 8 to 12 years of age. And the interesting part in this study is that when they looked at the number of children where they had dental trauma and never seen a dentist, 71% of the population. When they also looked at those, if they looked at those who actually went to the dentist, you will see that 23% of them didn't have their actual teeth treated. Oh, it's working now. Now, when they looked at the time elapsed between trauma and going to the dentist, they found that almost a third, actually a third, was seen within a month, but another quarter of the sample was seen even further, later than a month, which is delayed. This is the interesting table, actually, I wanted you to see. The authors actually said that there were 18.3% what they call dentist negligence. And what did they mean by that is that a lot of those children actually went to the dentist, but the dentist failed to restore the teeth or do the appropriate treatment. So that actually raises a big question on why these GDPs are actually not providing the treatment. So that generated a couple of questions in my mind when I prepared this lecture. So I wanted to share with you two surveys. The first one was about a survey about the education, undergraduate education in the management of dental trauma, which we've done in the Arabian region. It was an online survey, and we sent it to the program directors of these schools. And as you can see here, we had 30 schools that responded. And out of those, you will see that in the primary dentition here, theory only was, half of those schools were only teaching the students theoretical management of trauma in the primary dentition. If you look at dentition, you will see a similar trend. So there are a lot of schools in our region that don't actually offer practical of training for these students. Now, we could understand this because trauma is not really an easy thing to find. It's rare to start with, and also to find the numbers for the students would be a challenging thing. So I could understand that. However, it is a limitation to the knowledge of our graduates. So the students will graduate and they will only have some theory about management of dental trauma. So they will not be comfortable or confident doing that. Now, when we ask the program directors, do you think that the training is enough? And if you look at the column at the end here, the dental trauma one, you will see around a third of these program directors actually felt that the training wasn't enough. So another survey that we've done in our region, which looked at the graduates, so the general dental practitioners. Now they graduated and they're now working in the private or non-private public sectors. And we focused on two things. We focused on knowledge and we focused on confidence. And unfortunately, we did this during the COVID time and people were very frustrated and there were too many surveys going around. So we only had 323 people respond. Okay, so it's not a massive or reflective sample. However, the distribution in the sector, you can see that the majority of them are actually in the private practice. But the interesting is we asked about the knowledge, we asked two ways. The first one, we asked them, where are you getting your knowledge from in the management of dental trauma? And as you can see here, that the majority were using local protocols. I wish we asked them at the time, where are these local protocols coming from, but we didn't. But the majority are using local protocols. Some are using combination of the IADT and their local protocols. Some are actually just using the IADT, but it's not as big as the local protocols. The second question we asked them was clinical scenarios, and we chose 2 clinical scenarios, one of which was a very basic scenario of a 7-year-old who had complicated crown fracture. They came within, I think, few days or even less, if I'm not mistaken. And we asked them, what would your treatment be? Now, luckily, half of them answered the correct answer. But what was absolutely worrying is that 94 practitioners were going to devitalize that tooth, although that tooth could be saved. So this question, or this table alone, highlights the critical knowledge of our GDPs in our region. Again, it's not reflective because we don't have a good enough sample of the whole region, but still, I have 100 dentists who are gonna devitalize an immature tooth unnecessarily. Now, we also asked them about confidence, because you could have the knowledge, but you might not have the confidence to do the treatment. And we gave them a scale from 1 to 5. And 1 will be the least confident, 5 would be the most confident they are. So as you can see, with uncomplicated trauma, the simpler the trauma is, the better the confidence. If you look at the other end of the spectrum and you look at avulsion, for instance, you will see that the number of those who consider themselves very confident went down to only 22%. So that also shows us another aspect. It's not just teaching them, it's also about their confidence in treating these patients. Now, we asked those that they said that they are not confident, or they said they're lacking the confidence, or those who chose 1 and 2. And we asked them why. It's understandable that 66% would say because of the lack of experience. But the interesting ones are the second, third, and fourth ones, in which there is 60% who said lack of training in the management of traumatized permanent teeth, 9% lack of Arabic trauma management guidelines, and the third one is lack of English easily accessible guidelines. Now, to me, that is a little bit strange, because there are easily accessible guidelines online. If you go on the IADT website, there are guidelines available free of charge, and they are translated to 16 languages, one of which is Arabic. So that tells me that these colleagues don't know what is out there. Now, we are lucky in the field of dental traumatology to have had Prof. Andreessen, the late Professor Andreessen, who passed away recently, and he is considered the godfather of dental traumatology. Almost all what we know about dental traumatology came from his work. And based on his work, the International Association of Dental Traumatology was established, and they have produced evidence-based guidelines. And these guidelines are reviewed on a regular basis. And as I said, the source, or the aim of today, is to critique the 2020, which is the latest update. Now, interestingly, when we asked our 300 people, do you know of the new 2020 guidelines, you can see that 60 The Dental Trauma Guide is an online interactive source. So you don't really need to look through pages and pages. So you just log in, and then you just choose the type of trauma. You can choose primary or permanent, and then you choose the trauma intrusion in this case. You then choose the treatment. You could choose prognosis. You could choose whichever, and then it will immediately give you the treatment. So if you are very busy in your clinic, and you have a patient coming through who has intrusion, you can easily, within few seconds, you could go in and revise and remember what should be done. They even have videos there or illustrations on how you clean the tooth, how you reinsert the tooth, how you put the splint. So it's an amazing resource. But again, when we asked our 300 respondents, as you can see, 70% of them didn't know that this resource existed. So online resources are very useful. However, they are underused, I think, at the moment because lack of knowledge. And I think another problem, there are two problems with this website. The first problem is that you have to pay for it at the moment. And I think it's around $30 for a whole year. The other problem is doesn't have Arabic translation. But I contacted the organizers, Prof. Lars Anderson, and we are now translating the website. So we are going to translate it into Arabic. So it would be available for anyone who, or from the Arabic people who don't speak or haven't studied dentistry in English. So going back to the question that we said at the beginning. So why did these children go to those dentists and the dentist didn't provide the treatment? And thinking and preparing this slide, I was thinking maybe it's the education, as I told you. We're not training them enough undergrads. When they go into when they finish, when they graduate, maybe there aren't enough resources or training opportunities for them. Maybe we need to create regular online training packages for these dentists to be able to be in touch with the new knowledge or the new evidence-based treatment of these patients. Support is another thing. In Leeds, we used to have people calling us at the dental college asking, what should we do? So people that the general dental practitioners in Leeds, they knew that they can call the dental institute. There will be someone there who would answer them. So support is a good thing to have. Referral pathways, and I think in Qatar here, if you see an emergency or a trauma patient in the PHCC, you can refer easily to us. And recently we've created a quicker way of referral. So we have specific people that would contact with us if they have a patient with trauma to send it immediately to us. But I feel the private is not, because the private are a little bit distant from the PHCC and from us. And I think most of our colleagues in the private, they just send the patient across to say, just go to the PHCC or go. There isn't a clear fast track referral to us. And finally, maybe we can look into legislations or what they call here in Qatar privileges. Maybe, and again, maybe we can say, well, the GDPs can only do this and this and this in traumatic injuries, but more complex work should be referred to us. These are the things that I thought of that might help improve the management of trauma to these children. Now that takes me to our topic of today, which is the critical appraisal of the 2020 guidelines. So I have already shown you the importance of these guidelines. They are the guidelines to go to in the management of dental trauma, especially if you are not experienced. Many of the experienced might argue that the information there is not correct according to their experience. But for the general practitioner, for those who haven't had the experience, these are the most important guidelines. So before I go through them and critique them, I just wanted to clarify that we have to be also reasonable, because the field of dental traumatology is not an easy field to do research in. You don't have enough cases. You don't have, you might want to treat them at a certain stage. So actually being there at that stage is not easy. So most of the publications that you will see are falling within this area. So there are cohort, case controls, retrospective studies. Very rarely that you will find randomized control trials, because it's very, very hard to have. And also a lot of what we know is actually based on expert opinion rather than solid scientific evidence. And to prove that point, this is a paper published in 2014, which looked at the top 100 cited articles in dental traumatology. And you can see that the majority are observational studies, and only out of these 105 experimental studies, which shows you that this field is not easy actually to design randomized controlled trials or clinical trials. So let's look at the 2020 updates in closely. So there used to be 3 parts. Now they made them 4 parts, okay? They introduced one that is called general introduction, and then primary dentition, permanent dentition, and dedicated a single one for avulsion at the end. And these are the aspects that I have picked from these guidelines to discuss with you. Some of these aspects, I feel that they were amazing additions. Some I feel I'm not sure about that, and some I will convey to you my concerns about. So the first one, which I think is an amazing addition, is what is known as the core outcome sets. And for those who don't know this, it's actually led by a team from Leeds and around the world, and I think Prof. Dugal has been involved in it as well, in which, as you know from this pyramid of evidence, that at the end, the best or the highest evidence is by synthesizing all of that into systematic reviews and analysis. So if we can do this, we will manage to get better understanding of the research, especially in a field where we cannot do a lot of randomized controlled trials. And for, I think, our undergraduate students who are with us today, I've just prepared these 2 slides just to explain the concept. So for you to consolidate and to merge the evidence together, you need these studies to be giving you the same outcomes. So if you have 6 studies, and these 6 studies are giving you different outcomes, 1 on quality of life, 2 on pain, 1 on success, and 1 on survival, then you will only be able to synthesize the 2 studies that are talking about pain. So you've already lost 3 studies, and you were not able to synthesize it because of this. However, if you have the 6 studies giving you the same outcomes, you could take that into your analysis, you could synthesize the data, and you would be able to get some more information about this field where you are unable to get a lot about. So what they did is they created a list of what they believe should be reported in trauma. They have a generic list, like things like pulpal healing, pain, discoloration, and so on. So these should be available, should be included in any trauma case, okay? And then they have a list of specific trauma and what else should be reported. So if you hear an example of root fractures, then they added to that that you need to put the level. So you have this generic list, and you have to add to that the other things. So later on, if we are reviewing root fractures and we want to look at the success depending on apical, middle, or cervical fractures, we will have that information. So I believe this is a fantastic addition, and I hope a lot of my colleagues who are recording dental trauma would actually make sure that these items are there. Now, in the management of primary teeth, there are 2 aspects that I want to highlight. Again, I was reading the guidelines, and I'm trying to highlight the things that changed and also the things that didn't make sense to me. So when I read about the complicated crown fracture of a primary tooth, as a pediatric dentist, the first thing I would do is a pulpotomy, regardless of the size, regardless of anything. That would be my treatment, because I know pulpotomy is highly successful, 96% most cases. That would be my decision, complete coronal pulpotomy. But what they said now, they said that you consider using partial pulpotomy and using calcium hydroxide. Now, these 2 things are new to me, because we don't do a lot of shallow pulpotomy or partial pulpotomy in primary teeth. And also, we don't usually use calcium hydroxide. If they said if you have a cervical, so you do cervical pulpotomy if you have a larger exposure. So that made me think, as a pediatric dentist, what has changed really? Have I missed something? Because as a pediatric dentist, and a lot of the weak evidence is showing, if you put calcium hydroxide on primary teeth, you end up with internal resorption. So I wanted to know what has changed really. Why did these guidelines change? And again, if you look at Cochrane in 2018, they already told us that that MTA is much better than calcium hydroxide, and they told us that using formicrosol is much better than calcium hydroxide. So always calcium hydroxide goes here in our material used in pulp management of primary teeth. But after search of the literature, I managed an even hard search of the literature, not an easy one. I've managed to only find 2 papers. This is a study which comparing calcium hydroxide partial pulpotomy to formicrosol pulpotomy in children, and they have reported that there was no difference between these two techniques. So if you use a partial pulpotomy with calcium hydroxide, you will get success as good as the best material we know of, which is the formicrosol pulpotomy. And also they said both techniques cause internal resorption to the same level. So that's an interesting finding to me as a pediatric dentist. Another study looked at partial pulpotomy, but using MTA. So they used mineral trioxide aggregate in comparison to, again, formicrosol complete coronal pulpotomy, and showed the same result, that the use of MTA partial pulpotomy and, sorry, as a technique using MTA or calcium hydroxide is successful. So again, going back to my dilemma of what do I do now, because up to this moment, that technique and calcium hydroxide hasn't been anywhere under my radar. So it made me think, it might be because most of the studies that we know about calcium hydroxide are because of caries rather than trauma. And caries, you will have months and months of exposure. So you have a very chronically inflamed pulp. But if you are looking at trauma is usually a few hours of an exposed pulp. So maybe that's why calcium hydroxide or shallow pulpotomy would work in traumatized teeth rather than carious teeth. The other thing that I was thinking about, okay, now let's look at the failure. Now we have been leaving calcium hydroxide for all these years because it causes internal resorption. But we now know that internal resorption really is not a big deal. The teeth become asymptomatic or stay asymptomatic until they exfoliate. I'm talking about primary teeth here. This is a patient that I actually seen recently. This is a patient with cerebral palsy that had dental GA in 2016, not by myself. And they have done pulpotomies, as you can see. And when I reviewed her in 2021, as you can see here, she had multiple internal resorption. She had no pain. I only took this X-ray because of the recall and because it's been so long since she had any X-rays and because her crowns were perforated. So I wanted to make sure there isn't anything I'm missing. But as you can see here, lots of internal root resorption, no symptoms in a patient that I cannot treat under anything under GA, other than under GA. So really, it's not a huge deal. What else could have caused this? So if I go back to my dilemma here, again, we have some promising results, some studies. Again, we need to consider that. And the other thing that we need to consider here is also nowadays we have these, there's the element of discoloration because of MTA that we have to keep in mind. So to me, how is that going to affect my practice if I see tomorrow a child coming through the door with a complicated crown fracture in a primary tooth? Personally, I would say if it's a small clean exposure, then I would consider partial pulpotomy, but I would prefer the biodentine, the non-discoloring MTAs. If it is large exposure, if it's complicated or contaminated exposure, I would tend to still do a coronal pulpotomy. That's my approach and my understanding of the evidence here. The question is, what would I do if I only had calcium hydroxide? I think in a clean exposure, I would possibly use it. But again, until we get more evidence, I would be more comfortable using the materials that have a bigger evidence behind it. So that's my take on this part, which is what do I do in complicated crown fractures. The other fantastic addition, and I say fantastic because it should have been there long ago, is management of intrusion. In the past, we were told if the tooth is going labial, monitor it. If it intrudes labially, monitor it. If it intrudes lingually, it will affect the tooth bud, take it out. I haven't had that. I haven't done that since I went to Leeds in 2004. Because everybody, when I went to Leeds, they looked at me and they said, why? They erupt. And since then, I have never extracted an intruded primary tooth in whichever direction because they erupt. We know that they erupt. So I'm very happy that they have changed this. And if you look at the evidence, you will see that there are studies that showed that there is a high percentage of re-eruption of these teeth. To be honest, I'll answer that because I saw a patient the other day and the primary tooth went in and horizontal. Okay. Now, my only option is that I cannot see the root. My only option was a general anesthesia to take it out. So I told her that, listen, let's just monitor and see. If anything happens, pain, blah, 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 come back and see me and we'll sort it out. The tooth came out. It erupted. It just erupted. I was hesitant. I was like thinking, no, I'm crazy. I'm going to cause this child some pain unnecessarily. But it erupted. It erupted in a wrong position. It didn't look fantastic, but at least I could wait a couple of years, take it out for him on the chair, rather than an urgent GA for a treatment that's not needed. And I think, Prof, you've just, yeah. Unless it becomes ankylosed or causes infection or pain or anything, then you have justification to take it out. If it also has a complicated crown fracture, pulp exposure, yes, yeah, primary teeth. We're not talking about permanent teeth here. So that's another introduction that I completely welcome, and I think it's a fantastic addition to the literature. Now, in the permanent dentition, I'm going to highlight 3 changes, which I think also some of them are amazing. There is this paragraph about CBCT. Now, they have stated that for CBCT, they recommend doing it in partial root fracture, so particularly root fracture, crown root fractures, and lateral luxation. But the key message here, to me, is whether the image is likely to change your treatment. A lot of my colleagues just take CBCTs, just see what happens. But if it's not going to change your treatment, why are you going to take it? It doesn't make sense. So I'll show you a few examples. These examples, the first 2 slides came from my colleague Noura Al-Shahawi, Noura Saif. She's an associate prof in Cairo University, and she was kind to share these slides with me. And these are periapical or upper standard occlusal of root fractures, and they can show you some information. But if you take a CBCT, it will give you more information, more valuable information about root fracture that a 2x2 X-ray would not show you. I think that would be helpful to me in managing this case. Another example here is this mandibular fracture. And as you can see here, from the CBCT, I can see a buccal and a lingual fracture. It's a complete fracture. So that also is useful in taking. But what about this case here? This is a patient who avulsed the upper right tooth and then reimplanted, taken an X-ray, and there is a replacement resorption. So my treatment for that patient would be decoronate. It's already almost 1 or even more millimeters. So I would highly recommend, actually, no, looking at the cervical lines, it's intruded considerably. So this tooth needs decoronation. It doesn't matter if I have a CBCT. What would the CBCT show me that I already don't know? So again, taking a CBCT, I don't think in that particular case is useful. And I'm hoping whomever is listening or you agree with me, because as I said, this business of just CBCT and trauma, I hope it will stop, because I think we are over prescribing CBCTs for some of the patients. Another two changes in this category is the management of crown root fractures. And I might upset the endodontists here, so I do apologize if I upset you. So what they said here, for immature teeth, use partial pulpotomy. We know this, and no problems there. In mature teeth, go for pulp extirpation. Now, I could understand that in an adult, which makes sense. You extirpate RCT, post, crown. In a growing child who there's the element of cooperation, the element of growth, sometimes going all the way to do this is not the right approach. And in Leeds, we tried our best to preserve the pulp and restore the pulp. So I would still try the concept of coronal pulpotomy, coronaradicular pulpotomy, and this is a case in which, as you can see, we kept going until we managed to find healthy pulp tissues in the canal, and we stopped, and we did our calcium hydroxide, we sealed it, and we built it. Okay, so again, if you look at this X-ray, I think my endodontic colleagues might say, well, they might have some root canal obliteration. You might make our life difficult in the future doing us. I can see Dr. Dilek shaking her head. We can agree on this, but I feel this is something that we should consider. Again, I'm not saying it should be the only management technique, but it's something, I don't know if Prof. Dugal has any. Mhm. So that's, oh, we have, yeah. Yeah, that's very good point, fair point. If the patient comes for their follow-up, we can pick up any sign of pulp obliteration and act on it at that time. So that's my take on this second point. Then my last 2 points is one on intrusion and one on avulsion. And I think we're still okay with time. So intrusion is the biggest one. And intrusion in 2012, we used to look at the level of intrusion. And if it's immature tooth, as you can see here, if it's less than 3 millimeters, 3 to 7 millimeters, allow the tooth to erupt, wait a few weeks. If it's more than 7 millimeters, ortho or surgical. And to be honest, with all the cases I've treated, I've always went for ortho. Not to say there is no space for surgical, but I've had so much success with the ortho repositioning. But if you look at the 2020 guidelines, they have done a blanket. If it's immature tooth, any level, even if you cannot see the tooth, just leave it for 4 weeks to erupt. Now that made me also think again, and I'm like, but that to me doesn't make sense with the severe intrusion, because you have this crushing trauma, you have these periodontal ligaments under pressure, you have damaged the cementum, and there is contact between the bone and the tooth. And if I leave that for a long time and it ankylosed there, it's hard. If I even bring it down to the level of occlusion and then it ankylosed, it might even be better for the patient. We can postpone anything in the future. So I looked into the literature to see what has happened to make our colleagues at the IADT change the guidelines. And I came across the systematic review and meta-analysis, which I think is the reason for this change. So I looked deep into that paper and I looked at this. They have this amazing graph there, or table, sorry. On this side, there is the outcome that they looked at in each paper, and they compared spontaneous eruption to surgical repositioning to orthodontic repositioning. So these are columns comparing different techniques. And then when they looked at general, any tooth, regardless of root formation technique, they looked at root resorption. Is there any difference between the techniques? And they found that if you compare spontaneous with surgical, there's no difference. When you look at marginal bone defects, actually it was better for spontaneous repositioning. When they looked at pulpal changes, it was better for spontaneous re-eruption. And when you now look down in there, they are talking about incomplete. Now we're talking about immature versus mature. And here, they looked at marginal bone defects. And again, they showed better results with spontaneous re-eruption. Pulp changes, they looked again, and they found better for results are better for spontaneous re-eruption. So if I look at that, I agree with them. Really, all of this data is showing that if you leave the tooth to re-erupt, you will have much better outcome than if you surgically reposition it. But again, if you read it carefully, you will find some limitations, some really good limitations there. Let's forget that we don't have clinical trials because we said it's hard to get clinical trials. But when they looked at root resorption, they have merged replacement resorption with infection-related resorption. There are two different types, two complications that should not be merged together. But because of the low number of studies, they merge replacement resorption with infection-related resorption. Replacement resorption cannot be treated. Infection-related resorption can be treated. So you cannot merge these two together. Also, they didn't have any studies about orthodontic repositioning to compare to, only looked at spontaneous versus surgical. Another problem is now we're looking at immature versus mature, and they didn't even look at resorption as an outcome. They only reported on marginal bone loss, and they reported on pulp changes. So here I'll move that. So no assessment based on severity. And this is the key one. Now the IADT is telling us, now regardless of the severity, leave it to re-erupt. And the authors of this, they have clearly said there is not enough studies or evidence to actually tell you whether it's better to do one technique or another based on severity. So how did we make the decision to actually say, whatever the severity, leave those teeth to re-erupt? And I have reached out to our colleagues at the IADT because some of them are good friends of us. And to be honest, I haven't received an answer yet on what is the evidence that made you go with that. And I think, again, going back to my point, I think the evidence is possibly the expert opinion. And maybe some of our colleagues have had good results with severely intruded teeth, left them to re-erupt, and they did. We don't know. But to me, as a clinician, I'd be very, very worried here. And here, I would not say, as a pediatric dentist, if I see a patient tomorrow with severely intruded permanent immature tooth, I would still consider either surgical or orthodontic repositioning. And I'm not sure what Prof. Dugal thinks of that, but I think I would personally still do that. I would not wait 4 weeks for that tooth to re-erupt. They have taken them out. They are not online anymore because I think they consider them old now. It's been several, yeah. I hope they do because they had at the time also some really good comparisons and good assessment of the evidence. So that's about intrusion. And my last thing is about the management of avulsion. Now, the good news is we used to treat these avulsions based on two things: root development stage and time. We don't need to worry about that anymore in terms of management. Again, whatever you see, you just clean the tooth. I'm not going to go through these because you know these. You take the tooth, you clean it well, you clean the socket, you give local, you reinsert the tooth. That's the most important thing. And then you follow the guidelines on management these teeth. In terms of giving them antibiotics or not giving them antibiotics, the guidelines say it's up to you. There's no evidence. And mostly if you have like contaminated areas, low immunity, something like that, then give antibiotics. But they don't particularly stress on it. If it's immature, monitor pulpal vitality. If there is any sign of loss of vitality, then either apexification, revitalization, it's entirely up to you. If it's complete, mature, rooted tooth, then RCT. So that's the guidelines as it stands now. So there's no difference between less or more. So in the past, we used to take mainly the mature teeth that are more than 1 hour and scrape the periodontal ligaments and then reinsert the tooth. Now, the reason they stopped this for over than 60 minutes, I think, is this paper, in which even as you can see, it's Eva Loresden, Jens Andresen, Lars Andersen. These are the people who are in charge of the IADT and the Dental Trauma Guide. And they reviewed 400 avulse teeth. And the key thing that they found is that 15% of those that we previously used to say scrap the ligaments, who didn't have that, so the teeth just reimplanted without scrubbing the ligaments, 15% did not develop ankylosis. So that's why they said, well, actually, 15% still has a chance. Why should we do that? And there's another paper, another in vitro study by a very good friend of mine, Manal Maslamani. She was, we were studying together undergraduate at Leeds, at Just in Jordan. She also did this study in which she scrubbed some roots in I think dogs, and she reimplanted them in another group in which she didn't, and she found no difference between the two. So I think based on that, the guidelines have changed to not doing that. Another subgroup that the old guidelines used to say soak it in tetracycline or fluoride. That's also stopped, and the reason is there's some study. The reason that they suggested using tetracycline was based on these 3 animal studies, in which 2 showed better healing if you put the teeth in doxycycline solutions. But recently, a human study, has shown no difference. And this study compared 30 replanted teeth which were put in doxycycline in comparison to 36 teeth that were put in saline only. And they showed that there was no difference in terms of pulp necrosis, no difference in terms of replacement resorption. So I think that's why these 2 has been taken out. You don't need to scrub the periodontal ligaments. You don't need to have these solutions. Just clean the root, clean the socket, reinsert it as soon as you can. So again, that's why this was eliminated. And I think my battery is around to finish, so it's a good sign for me to stop here. So in summary, these are the points that I think there were fantastic additions to the new guidelines. For the crown root fracture, I would consider coronaradicular pulpotomy. And for the intrusion, I would still personally follow the old guidelines in terms of the immature teeth. And with that, I thank you all for your time and happy to take any questions. And not an hour yet. So you need me to mute.
Thank you very much, Dr. Hani, for the
How many people are online?
presentation.
Pardon? 15.
So thank you very much for the fruitful presentation. Very nice. Thank you. So any comment, any question, please?
I can see.
Yeah. No, it's an amazing presentation. I really enjoyed. Not only you talk about the guidelines, whatever, but also all in depth on all the different details in the guidelines. I really enjoyed it. I have many questions and ideas. So one question that I'm curious is that it's about the issue of the resorption of the root, right? I think I'm not a pediatric dentist. I don't know much about this, but it seems that that's a big problem, right? The resorption of the root. What are the materials that cause resorption of the root, and which ones don't cause resorption of the root?
It's not related to the materials, it's related to the trauma itself. Mm-hmm. So if your trauma is going to result in removal of the cementum, I think if I'm not mistaken, 4 millimeters is the cutoff by some studies. If that happens, then there will be contact between the bone and the root. And because there is no periodontal ligaments, there's no cementum, the bone does not distinguish the root as root. And there will be bone remodeling, and then you end up with the body removing part of the dentine and replacing it with bone. So you end up with this replacement resorption. Infection-related resorption is usually related to the infection staying long time. If you add to that inflamed periodontal ligaments, you end up with infection-related.
But even from the, the resorption from the inside, like the one that you were.
The internal resorption.
Yeah.
Internal resorption is. I think Monty has a theory about calcium hydroxide and the primary pulp tissues. I don't know of exact reason, but I think it has to do with the inflammation or, yes. So I think you're applying calcium hydroxide with a high pH on an inflamed pulp, and then that is causing some more inflammation in the pulp, and that inflammation continues, and then you end up with internal resorption.
So the calcium hydroxide, when you put it, you get internal resorption sometimes.
That's the theory.
Basically, internal resorption is because of multinucleated giant cells. And multinucleated giant cells only differentiate in chronic inflammation. So there are two scenarios in which you can get internal resorption. In both scenarios, the pulp is vital. If the pulp is non-vital, you can never get internal resorption. So one is that after trauma, the pulp itself becomes inflamed. And if you don't treat the inflammation and it gets worse, you get then differentiation of multinucleated giant cells and then resorption. Alternatively, because calcium hydroxide is very alkaline, if you put calcium hydroxide on an already inflamed pulp, it makes the inflammation much worse, and that triggers the differentiation of macrophages or multinucleated giant cells, and then you get internal resorption. So basically, it is the inflammation that causes internal resorption.
And with other materials, you get the same problem as with calcium hydroxide?
If you put tricalcium silicates, for example, if the inflammation goes away, then you won't get it. But if the inflammation is there and the giant cells differentiate, then you will still get it.
So it's
the results are much better with the other method, more like the MTA. You do not get internal resorption.
Yeah.
You get it also with ferric sulfate. So ferric sulfate and calcium hydroxide are the two ones that
cause internal resorption.
That are known to cause.
It's not the materials that cause it. It's the effect on the pulp that causes the inflammation. It's the pulp. The resorption is from the pulp.
But some materials do better than others.
Some do better than the others. Yeah, it's the problem with calcium hydroxide. It's a great material, but because it is so alkaline, if you put it on a healthy pulp, it causes healing, because then you get the bridge formation. If you put it on an inflamed pulp, it makes the inflammation worse. So it's a very fine line when you use calcium hydroxide between putting it on a healthy pulp and on an inflamed tissue.
But that tends to happen more in primary.
Yeah.
I think this is the point that I get a bit, not confused, but I think we need more studies, because why in the primary dentition you tend to get that much more than permanent? Because in permanent we do similar situation and we put calcium hydroxide and do Schwick pulpotomy, and the success is 95–96%. But in the primary dentition you end up with most of the cases internal resorption. But again, most of these studies that looked at that are from the 70s, they're very old, the technology was not that great, and the minute we ended up with new materials, that old stuff.
You see, what people did was, people suddenly thought MTA was great, right? They replaced calcium hydroxide with MTA. Every single tooth you put MTA on the coronal side becomes discolored. So MTA should never be used. MTA is only meant for apical. If you put MTA in the coronal part of the tooth, it causes discoloration. Even now that they have replaced bismuth oxide, which is the opaque in MTA, with zirconia, even those are discoloring. So if you're going to use tricalcium silicates in the coronal part, better to use biodentine, because biodentine does not cause discoloration. MTA does. So I would never use MTA in the coronal part of a tooth, ever.
Even the cervical part is even in the coronal part of the root canal, it makes.
Yes.
Yeah, that's what I'm saying. You should never use it in the coronal part. Yeah, it's because of the
coronal part of the root canal.
Yeah, it's because what happens. Yeah, even if you put it there, you can actually see the gum tattoos.
Gum,
yeah.
yeah.
It's but a lot of now they're making a lot of MTAs without bismuth oxide. They're using zirconia, but even that is discolored.
White MTA is same with the gray MTA. Never.
Same.
To a lesser extent, but it's still
less. Yeah. It's like, people started using lead-mix in trauma, and that was a disaster because lead-mix also had tetracycline, it caused discoloration.
I think Peter Day's study showed that.
Yeah.
Still, we have some internal results unexplained about trauma without history of trauma, internal resorptions.
Internal resorptions there has to be some inflammation, otherwise you can't get it.
I don't think I come across any internal resorption for no reason. Usually there might have been a trauma that the child or the patient is not aware of.
Insignificant trauma,
but for it to just happen, nothing. Dr. Dilek?
Thank you for excellent presentation. I really feel that I'm updated.
That's the whole purpose.
Yeah.
But actually,
that's the software is updated.
Just to say, I haven't covered everything. There are another 3-4 amazing extra additions to the guidelines actually. But if I add everything, it will be boring, and also it will take away from the main message.
So there is a question regarding translating that website which you talked about in the Arabic. More than 80% of dental colleges in the Arabic world, you teach in English.
True.
And we have some sort of, let us say, small percentage they teach in French. And we have maybe less than 1% teaching in Arabic.
True, but I think in Syria, it's taught in Arabic. So the whole of Syria are teaching their students in Arabic.
But our dentists are not all Syrian.
No, I'm not talking about just us, but you need, there are children in Syria that will have trauma, that I would love their dentist to actually access the website and treat them and find the knowledge. So again, it's not the reason why this is happening in our region. It's one of the reasons. And if you you're right, because if you look at the survey, I think there were 9% who said the reason or one of the reasons was the lack of Arabic. So 9% of 312. You're right, but I'd rather these 9% find good resources to actually treat those children.
The translate in Arabic, I'm sure another group, they need translation of the Arabic.
I have an answer to that. When it comes to the terminology, I'm going to ask them to allow us, if you put the mouse on it, to show you the term in English.
Yeah, it is not easy.
Because otherwise it's hard. I'm having difficulties translating it because I didn't study in Arabic, so it is hard. I think Dr. Dilek didn't finish her question.
About evolution cases, some dentists prefer doing the root canal treatment out of the socket before insertion into the socket, and this is for closed apex, and after 1 hour, if it comes in dry conditions, now it is all unacceptable, right? Doing the root canal treatment, before.
No, yeah.
I think the idea is linked to that 15%, because in the past we were going to scrub all these ligaments. So whether they survive or not doesn't matter. We're removing them.
Because
so I can
do. Right? When you scrape, they will ankylose. The tooth will ankylose.
They all ankylose. Most of them ankylose anyway.
Yeah.
So it wasn't really a great step, but the research had at the time recommended that you remove the periodontal ligament because they will not survive and they will cause infection and inflammation. Yeah. So at the time, the advice was to remove it, and because it doesn't matter, time is no longer an issue.
Root canal treatment, right?
You can do it right away and put it back. But now, because they're saying 15% will not end up with ankylosis or might not end up with ankylosis.
So whether the tooth
so
dries
put
or
the
not.
tooth back
Yeah.
As
So
soon
whether
as
the tooth dries or not, you don't scrape the tooth surface,
No.
you just put it and
clean it.
it might or it might not lead to ankylosis,
Yes.
but there's only 15% chance that it will.
Better than
Yeah, yeah.
15%.
Better than 100%
chances.
anyway.
Yeah.
And my second question, why is it not free, this guide?
The website.
The website.
It used to be.
It was free.
It was free.
I was advising my students during my lectures. I mean, just go to the...
It was free. As you know, I think I still am. I haven't been active. I've been on the board of the trauma guide since it started. All our lecture fees, anytime I gave a lecture, anywhere, I used to donate my fees to the trauma guide. There was also some money coming from Jens Andresen's books. We used to put that into the kitty as well. But there came a time when it was just too expensive to run it. So there are two statisticians who are constantly updating the trauma website, the trauma guide. Their salary is, we were paying them something like 40,000 pounds, 400,000 Danish krones per year. So in the end, we just didn't have enough money to pay. We ran out of money. So now you can get, it is still quite cheap actually. We can take institutional subscription. It's only $100 for an institution. So once we start our clinic, we will get that, and then we will all have access to the trauma guide on the institutional subscription. So it is just a question of, now Jens died, he's passed away. Now the website is being looked after by Lars Andersen and Eva Lauritsen. They have no money. I mean, the money is, Jens Andresen used to put all his lecture fees, his books. I used to put all my lecture fees, always.
But usually guides are free, as long as I know.
No, you can still access the guidelines.
American
Guidelines, you can get them for free. It's the trauma guide.
It's the interactive website.
It's the interactive trauma guide.
The actual guides are there.
What happens if we do our own website? Like, would that be okay, or is it
You
okay?
can do it, but it'll take you ages to do it.
No, I think I've seen your presentation a while back where you started something like that.
Yeah, because I did a copycat of the website. But it's not as sophisticated as that one.
The trauma guide is very sophisticated website. See, the trauma guide has the biggest advantage trauma guide has. It's not, you have to differentiate it from guidelines. A trauma guide tells you what to do now.
prognosis.
Yes. So, for example, let us say you have a patient with intrusion in your chair, right? You go click intrusion, then you pick, it says, what is the root development of your tooth? You click that. It'll ask you 2-3 more questions, you click. Then it says, dear colleague, I don't know if you've seen it. Dear colleague, we have 32 teeth in our system which match your case. Based on this is what is going to happen. So the chances of ankylosis, so much. Chances of replacement resorption, so much. So it will tell you exactly what to do. So it's not a guideline, it is a clinical guide. It tells you what you have to do next.
And the more cases they get, the more cases.
So who puts in the cases there?
We did all.
Yeah, okay.
So how many cases they have in that database?
It depends on the type of trauma. Sometimes you actually choose certain, because it's not just trauma, as Prof said, root development stage, and not only one, they will have 4 or 5.
There are 5 types of root development.
And also if there's any associated injuries. And when you put those together, sometimes
It's an algorithm.
Yeah, they tell you, sorry, we don't have any data.
Okay.
It's an it picks.
That's a very, very interesting point, because I had a question on that.
It says, scratch your mind.
So you're basically deciding your treatment plan sitting with the patient sitting on the chair, and you can just
That's
go
the
and
beauty
decide
of
your
it. Within a few minutes, you have that.
It's tailored to treatment approach.
Yeah.
So what is it?
Yeah, that's a very interesting thing, because at the beginning you were saying that there is an issue with the lack of literature on the subject, and I think that this is a problem that is affecting many areas of evidence-based practice. That in reality you cannot have a clinical trial for every single situation that exists in the world. It's never going to happen, and especially in situations like dental trauma, because there is limited cases. So this approach of having a database. It's been looked into in many areas of research that could be an alternative. Instead of having clinical trials, you just have a database and you just ask the questions to the database. And one way of making the databases as powerful as possible is through, for example, practice-based networks. So when you have a big network of clinicians that could be inputting cases in the database to make it.
The problem is, I think in Europe mainly, it's patient confidentiality and getting approval to actually share patient data with a website. So I think in UK, it's very hard to actually share the data with the dental.
As long, but you can hide you have to hide almost everything. And even the photographs have to be, even though you cannot identify the patient, you have to have consent. So it's quite tricky.
But in Copenhagen, which most of these data come from, they are, every time they get new case, they follow it and they update that data on the website.
It's like prototype of artificial intelligence.
Yeah, you see?
It's prototype of it. When artificial intelligence didn't exist, this guide was existing.
You see, Jens and Dresen from 1965 had every single case that ever came to the Riks Hospital, which is in Copenhagen, in his office. So his office was just cardboard boxes, X-rays, sheets of every single. That is why if you look at those series of papers, which were called the Mighty 400 papers, so there was 400 avulsed teeth. And he followed, there was 4 papers on the 400 avulsed teeth. Some of the avulsions were reimplanted in 1967. So the data starts from 1967. And so he collected everything as he went along. So he had lots and lots of cases. But on the other hand, he was great. I mean, a lot of the data comes from Andresen, but he also, a lot of the guidelines in IADT, because IADT worships Jens Andresen. A lot of the guidelines are influenced by his personal opinion, which is sometimes wrong. I don't agree with it. I tell him, I always used to tell him that I don't agree with it. I went to a lecture, a symposium in Copenhagen, and they were very strongly presenting this avulsion guide that everything should be left to erupt again, permanent teeth. And he had invited a lady from Finland who was sharing her cases, and every tooth which was allowed to spontaneously re-erupt needed further treatment later on with orthodontic extrusion or something else. And they were erupting in the wrong way, different way. Then if they erupted, they all needed some further treatment. And I was saying, why don't you just extrude them with orthodontics in the right way anyway? You're waiting for so long, the patient's walking around with a tooth here. Why don't you just put a wire and extrude it? So I never agreed with the intrusion guideline. But they had to do it in this because he firmly believed that intruded teeth should be left to spontaneously. But I completely disagree with it.
Yes.
Sorry, you had a question?
I just wanted to ask, like in Hamad Dental Hospital and in PHCC, when they have patients, what's the protocol? What's the guidelines? Do they have like checklists? What's the plan for the trauma patients that you're talking about? How would they follow up the patient later on? How would you follow?
I cannot speak about the PHCC because I really don't know. In Hamad, we are a tertiary center. So a patient comes in trauma, we will see them, we will treat them, we will follow them. We are a pediatric department, so we will do everything.
So what do you follow? What do you follow? How the guidelines?
Just
They have a
Hey, Dr. Asma, how are you?
Very good, very good.
Please use the link in the chat box to complete the evaluation and get your certificate. Thank you so much. Thank you so much.